the most benefit is realized when you move from doing absolutely nothing to just doing half of what we would really like everyone to do. When we have studied the measurement of that and its relationship to health outcomes in big studies, it's strongly related to mortality and cardiovascular disease and a range of other diseases. So we know it's important. As well as measuring resting heart rate requires almost no effort. You could do this on your sofa. But honestly, stepping up and down a box in somewhere in your house, it's actually easy enough. So they're both vital signs in that sense, and they will tell us a little bit better, both of them, how our body current health status is. And maybe we want to do something about it.
Hello, everyone. Sean and myself interviewed today a prominent scientist from the University of Cambridge, Dr. Soren Brage. So, Soren, welcome to our podcast.
Thank you very much.
You mentioned in some interviews that just 10 minutes of exercise per day may reduce the risk of cardiovascular disease by 17% and the risk of cancer by 7%. Can you tell us how many people participated in this research and what kind of exercise they performed?
Yeah, so this comes from a meta-analysis, actually, of several published studies. So it's not just one research study, it's a multitude of research studies. And our paper, which was published last year, accumulated all these pieces of evidence into a combined analysis. And we looked at mortality, cardiovascular disease, several cancers, and you effectively get a curve with each disease, and the dose response curves, we call these, are different. And then we report at different levels of this curve. And why the 10 minutes? Well, the public health guidelines is 150 minutes of moderate to rigorous physical activity per week. So if you divide that up with what you get per day, then you get a little bit less than 20 minutes, or a little bit more than 20 minutes. But we also analyzed meeting half of the public health recommendations. So this is where the 10 minutes per day message comes from, because what we observed was that the beginning of the curve, so that's the comparison of doing absolutely nothing to just meeting half of the public health recommendations, the beginning of that curve is the most steep. So that suggests the most benefit is realized when you move from doing absolutely nothing to just doing half of what we would really like everyone to do. So that is where that 10-minute came from. And indeed, as you say, they are substantial health benefits that are realized for really quite important health outcomes.
Fantastic, thanks.
Ask a follow-up question with this outcome. So in terms of you handling the big data, right? So you have those exercise, but sometimes like people are like they value exercise, they also eat healthy, right? They may be generally taking care of themselves better. So how do you tease out those parameters and really draw a conclusion that this exercise, not something else?
Yeah, very good question. So in each of the individual studies that underpin the meta-analysis, the individual researchers or research teams behind those analyses would have made certain statistical decisions around what factors they either measured and also what they adjusted for in their analysis. We picked the most adjusted analysis in our meta-analysis. So we picked the most adjusted result that we could get from the individual papers. And in many ways, that would be considered the most conservative.
Thank you.
Soren, I understand that you consider resting heart rate is one of the key vital health signs. So can you explain why do you have this position?
Yeah. So resting heart rate is very easy to measure. So that's the first key attribute of this measure. When we have studied the measurement of that and its relationship to health outcomes in big studies, it's strongly related to mortality and cardiovascular disease and a range of other diseases. So we know it's important. The reason why I like it is that it is very empowering for the health communication. So it's very easy to translate a research finding which uses resting heart rate as the exposure to the general public, because they can just go ahead and measure it. If they got a stopwatch and they can count, it's very easy to measure resting heart rate. And, you know, these days you could also use your phone's camera to do this if you can't be bothered to count. But it's very, very easy, and it's very simple, and it's very strongly related. And the other feature that is nice about resting heart rate is that when you start an exercise program, let's say you do nothing, even in a couple of weeks after you started some aerobic exercise training, you will see a response in your resting heart rate. You will see your resting heart rate decreasing. So fitter people on average have lower resting heart rates. Resting heart rate is not only a biomarker of cardiorespiratory fitness, but it is a biomarker of aerobic fitness. But if you have a fever, so if you have an infection, then acutely it will also respond to that. So, you know, you might have a couple of other things going on when it starts to change. But that underscores the issue of why it's a vital sign, because if you already know that your fitness probably didn't change over a week, but you see changes in your resting heart rate, you're probably fighting off something. So it's a very good idea to know your resting heart rate, and it's so easy to measure. So I think everybody should just know it and keep track on themselves, look after themselves, and if they feel a bit under the weather and they also have some supportive evidence in other quantitative measures such as that, then maybe it requires a bit of extra investigation. And during the COVID area, this was one of the measures by which we could early detect that maybe there was something wrong and maybe you should stay home for a couple of weeks because you might have got an infection that would impact on other people. So that it has really many attributes that allows people to action it, to alter their behavior as a result of knowing the value.
Okay, got it. Fantastic.
But what do you think about VO2 max? Which one could be the best predictor of the risk of mortality? Is it resting heart rate or VO2 max?
That's a very good question, but it is predicated on qualifying what we mean by better. So if we can measure things perfectly, then VO2 max is the stronger predictor. And has perhaps a more straightforward interpretation that it's definitely about your fitness. Okay, but if we were to measure VO2 max precisely, then actually we would need a maximum test. We would need direct measurement of the respiratory gases. Okay, you can do that. You can pay for it. You can go to a lab and have that done, but it's not something I can just do like this on my sofa, right? So what is the better predictor? Well, it's the one that you can more readily measure so that you can alter the things that will improve your health, right? So in some ways, resting heart rate is actually therefore still a better predictor. I should say the most epidemiological study, or most of these big population studies that have tried to measure VO2 max, they don't use a maximum test. They use a sub-maximal test because it's a lot safer, right? So not a VO2 max test in it, if you want to do it properly, that's not for the faint-hearted, and I mean that literally. So it's not without risk to do an all-out exhaustive test, okay? But it's perfectly okay to do a submaximal test, right? So you can step up and down for a couple of minutes of a step, and you can get some estimates that are still a dynamic exercise test type of estimate of VO2 max. Sure, they have more error in the estimate, but if you are tracking that over time, again, you can track your own progress on your aerobic performance in that way. And again, as mentioned before, if you start an exercise program, you will see that when you are performing the same test, so you might have some preferred tests that you do, after a while, you would see that when I perform the same work, I need fewer heartbeats to perform that work. My heart rate will be lower at the same level of work compared to in the beginning of my training program. So again, it's one of those things that, okay, but if you can measure it really easily, then it allows you to track things. So, as well as measuring resting heart rate, requires almost no effort. You could do this on your sofa. But honestly, stepping up and down a box in somewhere in your house, maybe you've got a staircase, or it's actually easy enough. It's actually easy enough. So they're both vital signs in that sense, and they will tell us a little bit better, both of them, how our body current health status is. And maybe we want to do something about it.
Mm-hmm. Thank you. Thanks so much.
That's the reason why we decided to insert a test which was developed by Soren's team into our app, Breath Now. So we give an option to our users to track both resting heart rate and also VO2 max by people just standing up and standing down on a box for 5 minutes. And then the app spits out the number, and our users can track it and see progress.
Yeah, very easy to do. That particular test was actually developed by the Canadians, but in a steady state type of version, much longer. People don't really have the patience for that. So for that particular application that you mentioned there, Dimitri, we shortened it and made it into a ramp test, did the validation work in the lab, and those versions of the tests have actually been used in national surveys even. So they are very easy to do. And the national surveys we have in the UK are typically conducted with nurses going around in their cars to people's homes, knock on the door and say, hey, I got a step. Can you step up and down this? And I'll measure your heart rate. And it will give a reasonable estimate of people's cardiorespiratory fitness.
Has anyone done a research, actually, whether that proliferation of wearable devices improved somehow the public health?
So there was a recent paper that came out in American Journal of Preventive Medicine by Woodruff, and they looked at death from cardiovascular disease from 2010 all the way up to 2022. In the beginning of this over a decade, so from 2010 to 2019, the death rates from cardiovascular disease is steadily declining. Okay, so that's 2010 to 2019. Yes, I know what happened in 2009. We'll get to that. Okay, so hear me out. So at the same time, of course, many more people will have wearables, right? So a naive analysis will say, so this goes down and that goes up, so that means it must be inversely related, right? Yeah, well, a lot of other things happened from 2010 to 2019. We got better at treating cardiovascular disease, for example, right? So our treatment got better. So, of course, a person with a modern medicine hat will say, well, there you go. We got better at treating cardiovascular disease, and therefore fewer people die from it. He would also be right. Well, what do you think happened from 2019, 2020, when we had the global pandemic, and then onwards? Well, basically, all those gains in decrease in cardiovascular deaths were basically annulled, right? They just went back up to the 2010 level because Well, the hospitals were closed and not accessible to people, and loads of other things happened. So, just giving people a smartwatch for Christmas, it might not have solved the problem all the way up to the next Christmas, I'm afraid. So it might help. I think it's a great thing. I have one. And it gives people access to quantifiable behavioral evidence, but it's not enough. You have to change your habits, and you have to work out those habits so that they work those habits into your general structure of your day, so that they become consolidated and not just short-lived. And come mid-January, then, oh, this gym membership is too expensive, I'm going to cancel it now. So the problem is the sustainability, right? We gotta move people from just try and do a little bit. Maybe it's just the 10 minutes a day, but then keep doing it. Because actually then we would make a dent in some of those disease rates, which I'm afraid in most parts of the world are only going in the wrong direction. Early decades of doing health research, we were very much focused on what do the individuals need to do in order to improve their health. And in the beginning, we probably just naively thought, well, we just got to find out and then we'll tell people about it. And then, we go home for tea, it's enough. I don't think anybody believes that anymore. It's not that simple. That's part of it, sure. And providing people some quantitative evidence of roughly where are they on the dose response curves. Okay, that's also good, but it's still not enough. Okay, we gotta actually engineer our society so they are more facilitating to make the right choices about our behaviors, make them more welcoming to do physical activity, sell more healthy foods in the stores that are close to us, eliminating all the green spaces in our highly urbanized societies now, because the opportunities for being active are therefore diminishing if that was your preference to be active outside. So, it's a complex issue, but it doesn't only involve the individual and educating the individual. It involves everybody, all the way up to urban planners, traffic planners and policymakers, on how the tax system works and congestion charges and this, that, and the other. It's not a small agenda, is it? So we can help individuals, but we need the other guys too, right?
Yeah, like everyone needs to work together to make this happening. What is the main conclusion from the Finland study, which you're part of, and what is the impact on the public health?
Okay, so the Fenland Study is a study in the east of England of about 12,500 people. And we started that study about 20 years ago now. We've followed people up for a long time now. It's a cohort study, it's observational. So we observe people's behaviors and we measure lots of risk factors. So since it's a cohort study, it will have many questions that it would have tried to answer and have, I would argue, successfully answered. So the conclusions are many, depending on what those questions are. But I would say that we have provided fairly strong evidence that eating a healthy diet, diverse diet, full of vegetables, is definitely a good idea. Being physically active is definitely a good idea. Being physically active and have more of that activity generated through a little bit more intense activity, if you can, is a good idea. But if you can't, it's okay too, as long as you just do a little bit more light activity to compensate. So those are important conclusions about activity. We looked at whether earlier on we looked at some of the patterns of activity. So the public health guidelines used to be formulated around nothing counts unless it occurs in 10-minute bouts. Well, those restrictions, if you will, or conditions on counting our compliance with guidelines are now gone. And some of the analysis that we did in the Fenland study also contributed to that evidence, because we effectively found that, well, even all the short bouts, so get up and go to the other end of the office building here to pick up your cup of coffee or whatever you might do, well, those things also improve your health. So, and that's not the only study that did that, obviously. So, we reformulate the public health guidelines as a result of the accumulated evidence, right? It gets replicated in many studies so that we can say, this is actually real. This happens all over the place, but certainly that was one of the contributions. Other things we looked at was the density of fast food outlets, for example, and the correlations with people's obesity levels, and they are strong. So if you live if you pass more fast food outlets on your journey from your home to your work, on average, you will have a higher degree of obesity. So, and they are very different types of research. This last one actually resulted in a tool that we gave to councils so that they can take that and many other things into consideration when they approve or not approve new planning applications for the opening of new fast food restaurants or maybe slightly healthier alternatives. So maybe in one way we could say that did have some, that collection of research did have some public health impact. I think we would argue.
Awesome. Yeah, that's amazing. What would be the most surprising finding that you encountered regarding to this physical activity in the health outcome?
Yeah, it's a good question, actually, because in most of our research, at least we found that the direction of physical activity and health outcomes are as we expect, but maybe we don't always expect it to be quite so strong. So certainly when we looked at the relationship between objectively measured activity in UK Biobank in 100,000 people, and when the prospective data started coming in, just how strong those relationships were with mortality, with cardiovascular disease, with diabetes, they surprised everybody, I think. So, in our meta-analysis of self-reported activity across all these published studies, okay, is it sort of 20% or 17% or sort of risk reduction? Yeah, okay, that's probably what we'd expect. Okay, we start measuring the exposure more precisely. We're seeing that the differences are now 3 times as big as those previously observed. So I would say the magnitude probably surprised everybody.
Wow.
And that is replicated, but we need to do more of those, fair enough, more expensive studies, but they do really provide much more resilient evidence and less impacted by confounding than previous research were able to do, simply because of the technological advance.
Yeah, that's truly amazing. In terms of the type of exercise or the intensiveness, do you see any difference? Which one might be the most benefit for the health?
Yeah, so again, actually, for the mortality, we were able to see that even people who did the same overall amount of exercise or activity, if they were accumulating more of that activity and slightly more intense types of activity, then they would have an added benefit. So their mortality rate were even lower, even though they would be doing exactly the same volume of activity. So, the public health message for that is, well, definitely be as active as you can. It will benefit your health. And if you can, try and dial up the intensity a little bit and go for a brisk walk. If you can. So if you're going for the same walk, well, just try and speed up a little bit, because actually you'll be home earlier for tea and you would have added benefits in terms of your health.
And then what might be the biggest challenge in terms of measuring those physical activities in large populations?
So the biggest challenge is still to try and incorporate objective measures in either the big studies and particularly in understudied populations. So we need to do much more research in Africa and in parts of Asia for sure. Maybe we don't need to do that much more in Western populations, but we probably still need to keep doing a bit of it. So it's incorporating those in those populations that we have not studied well enough so far. So that's where collaborations definitely come in, where we can help each other and put the data together. And then I would say probably actually at this global surveillance level. So if the WHO wants to find out where the big predictors of human disease might come from, then measuring diet and physical activity are good things to measure, as well as smoking and all the other things. Yeah. It does currently measure that, but it's predominantly a self-report surveillance system. So if we wanted to know how big the global problem of inactivity is, then perhaps we should try and measure it a bit better. And I think we are moving in that direction. And someday we'll get there, but it's still a challenge to do that.
Yeah, thank you. I have a question based on your recent paper about the meat consumption and type 2 diabetes. I'm going to skip the different kind of meat for the diet, but could you elaborate on the use of the Federated meta-analysis approach in your study?
Yeah, so in contrast to the meta-analysis I mentioned before, which is a meta-analysis of published studies where you have to work with the evidence that the original researchers have written in their original papers, a federated meta-analysis is trying to do things ever so slightly different. It doesn't need to include published data. If somebody wants to give you access to their cohort data, but they haven't yet published this particular result, be it a small cohort, maybe it's underpowered, then even if they are not allowed to share the data with you on an individual level, then a federated meta-analysis can send the analysis code to the cohort and get the result back to the meta-analysis and then do the proper meta-analysis